So, I don't want to go over all the same points again, but I think I want to just make one point, that in the world of evidence-based medicine, we are trying to do things on the basis of evidence, and we know about the levels of evidence, and right at the top of the tree of evidence lies meta-analysis, and very shortly under that, the randomized controlled trial. I've been involved and have run a number of randomized controlled trials, and I can tell you it shortens your life. They are very expensive, they're very difficult to do, and those of you who have been involved in them probably know that. So they are very major undertakings, and I would suggest that a randomized controlled trial is not the answer to everything, and that there are some things for which a randomized controlled trial are useful, and there are some things that are not. And unfortunately, the STITCH trial is sort of back to front, because there is no evidence whatsoever, no randomized clinical evidence, plenty of other observational evidence, but no RCT evidence that in the absence of angina and heart failure due to coronary artery disease, that coronary bypass grafting is better than medical treatment. And actually, it would be nice to have settled that first, before the second study, which is looking at ventricular remodeling plus bypass grafting versus bypass grafting alone. So it's actually hypothesis 1, which I'm told is going to be coming out at the AHA, an initial study. This would be very helpful to know. Now, many of us feel in our bones that in the absence of angina, if you have true ischemia and you demonstrate hibernation, that you get benefit. But it hasn't been shown in a randomized trial. And so this trial, the STITCH trial, is really concentrating on this area. And I won't bore you with that. You're going to see a very nice video after coffee. Of course, the adverse effects of hibernation, we know, adverse ventricular remodeling, so geometric problems, electrophysiological instability, and diastolic dysfunction due to contractile problems. So it's a mixture of electrical problems, contractile problems, and geometric problems. And the idea behind this surgical ventricular remodeling is to enhance contractility, hence the need to do hibernation studies, something that didn't happen in more than half of the patients who were in the STITCH trial, to improve the efficiency of left ventricular contraction and to restore the left ventricle to normal geometry. Now, I know you have seen this in a different form, but it's just worth looking at once more. These are the big studies that those of you who know about this field will be very well aware of. So from 2001, 2004, Linda Michelborough from Toronto, O'Neill, and Lorenzo Menicanti, and the STITCH trial. And I just want to draw your attention to this column, just to make the point again, that the LV size reduction expressed as a percentage of baseline is in 30s, 50s, 30s, 30s, 70s, 19. So it's a very, very modest reduction in left ventricular volume, which was achieved in the STITCH trial. So I think from a methodological point of view, if you were to speak to a controlled trial expert, someone in our country like Stuart Pocock or those sort of people, they would say that this was a well-conducted trial from a methodological point of view. But, as you know, there was a very long period of enrollment. And when you have a long period of enrollment, the people who are involved in the trial are becoming more and more anxious as the target slope of recruitment starts to move away from the actual curve of recruitment. And the temptation is to recruit patients that aren't really what you intended to do in the beginning. Patients who actually are much fitter than the kind of patients who really should have been in the trial. And I think quite a lot of that happened. So there was a long period of enrollment, less volume reduction than anticipated. And it's interesting, as Lorenzo pointed out, actually, despite the fact there was a more complicated operation, it was a pretty benign procedure. There was no difference in clinical outcome. But the big problem was the lack of follow-up of LV volume and function, which was a basic flaw in view of the mechanistic hypothesis. And the study didn't specifically include patients with anterior hyperkinesia and large hearts. So the question is, was the hypothesis actually the correct one to test? So what I've been asked to do, which is virtually impossible, is to ask where to go from here. Well, you could try and do another randomized controlled trial. It's going to be very difficult to get people enthusiastic about it, and the people I'm talking about are the people who are going to fund a randomized controlled trial. However, it could be that it's worth considering a smaller randomized controlled trial with much more homogeneous patient groups and use physiological endpoints such as MVO2 or even very simple things like 6-minute walk, and certainly look much more at ventricular function. And then I think you have to recruit surgeons whose minds are not already made up. You can't actually do a randomized control trial unless there's equipoise. As you know, if you introduce a new procedure or a new operation, you don't do a randomized trial straight away because people are learning to do the procedure. If you wait too long, then everyone's decided this is the procedure that works, and so they're not prepared to let their patients enter the trial. So the time that you have to do a randomized control trial can be very, very narrow. And I think with the DOOR procedure, it's not a new procedure. It's a very established old procedure. It was evolved, as you know, from left ventricular aneurysm surgery and then was adapted to patients with hibernating myocardium and dyskinetic or akinetic segments, but not aneurysmal. So we've really got beyond surgical equipoise, and I think that's one of the problems behind it. So if you're going to do it again, if anyone's keen to do another trial, I think you've got to try and get equipoise. So you're going to have to find a group of surgeons who are even-minded about it. And then you might have, or you could do it a different way, and this would be, from a methodology point of view, quite a reasonable thing to do. You could say, well, there are the DOOR surgeons and there are the non-DOOR surgeons. So let's randomize the patients to that group of surgeons who are very keen on ventricular reduction, and we'll put the other group who are very good coronary surgeons who don't believe in it. And you could do it that way, but of course it's not such a good comparison. But it has been done. For example, in bilateral mammary, single mammary, you could send the patients who are randomized to bilateral mammary to the bilateral enthusiasts, and you could send the single mammary to the single enthusiasts. And it's something that we actually discussed with David Taggart when we were establishing the ARC trial, and we discussed that in some detail with the clinical trial experts in Oxford. And that would be a legitimate thing to do from a clinical trial point of view. Or we could look at mechanisms. And personally, I think that would be much more instructive, myself, than to do another randomized trial. We could look at pressure anterior wall thickness loops, and I'll explain what I mean in a moment. We could look at electromechanical left ventricular resynchronization. I don't mean ventricle to ventricle, I mean intraventricular resynchronization. And we, of course, with microdialysis techniques now, we can look at ongoing changes in lactate glucose, and particularly look at the extracellular matrix, MMP2, MMP9. So just let's have a look at this for a moment. We've done a number of studies over the years using transesophageal echocardiography. This is the ECG for timing. This is the posterior wall, and this is the anterior wall. Okay, and so we can measure the dimension, which is of course a surrogate for volume. I quite appreciate it. The MRI would give you volume, but on the other hand, you can't bring the MRI into the operating room very easily, nor into the intensive care where you want to study these patients. So this is LV dimension, and then inside the left ventricle lies a pressure transducer tip catheter, which measures pressure. So beat by beat by beat, you can develop pressure dimension loops. But in fact, you can measure the loop between pressure and wall thickness. So what this means is this area of the curve is an expression of the work done on the circulation by the heart. And it's quite sensitive. Now this would be a normal loop, and we can express it its size relative to the rectangle around it, okay, which would be the maximum theoretical fit. So you could express this loop as a percentage of the rectangle. And I hope for most of us in this room, it will be about 70 or 80%. And from that, of course, you can work out power. So if we go to these basic Newtonian ideas, we can get away from problems like contractility, which no one can define. So here are some changes. This is anterior wall thickness, and this is LV pressure on the y-axis. And these are changes that occur during coronary bypass grafting. So during the period of short-lived ischemia, then the release of the clamp and then finally we have restored pressure wall thickness loop. So you can see how revascularization has made a great difference between the situation before and the situation now. Now, you can define different types of asynchrony. If we look at pressure against wall thickness, you can see that things are going wrong. The pressure wall thickness loop is a peculiar shape, and furthermore, during isovolemic relaxation, the wall is thickening. And that's in primary asynchrony. And then in other areas, which are a reflection of that, secondary asynchrony, you get wall thinning during isovolemic relaxation. So the opposite of what should be happening. So I think by looking at this thing, you begin to get an idea of what's going on. Here's a patient operated on with hibernating myocardium, and here is the pressure wall thickness loop before we started. A very, very abnormal loop indeed, as you can see. Very abnormal. And then 30 minutes after completing revascularization, we restore a much better loop. So I don't want to go on about that, but it's quite useful. On the other hand, in non-hibernating myocardium, we start off, this is again coronary bypass grafting, we start off with a much healthier looking pressure wall thickness loop. Remember, this is the work the heart is doing on the circulation. And there is a slight enlargement of it after successful revascularization. And if you put this all together, if we look at cycle efficiency, if we look at peak, if we look at work, and we look at the rate of work, which is power, you can see that in hibernating myocardium, you've made a significant difference to the shape of the loop, i.e. cycle efficiency, to the work done on the circulation, and to the power. Whereas revascularizing non-hibernating myocardium, these changes have not occurred. So it does seem a very worthwhile thing to do, even though we can't prove it with level 1 evidence from randomized controlled trials. And if you look at regional myocardial ischemia, we know, it's known in 1936 by Tennant and Wiggers, regional myocardial ischemia results in impaired LV performance, and we know that the LV takes much longer to recover than the ECG does. And at peak stress, there's a marked fall in cardiac output. And stress-induced prolongation of ventricular activation is something we've been quite interested in. If you look here again, the ECG at the top, underneath there is a phonocardiogram just to show you where the aortic valve is closing, and this laser light doesn't seem to be very good, so I'll do it with this. This is to show you where the aortic valve is closing, and what's happening in this patient with coronary artery disease and impaired LV function is that the timing is wrong, that after the aortic valve is shut, the ventricle's still contracting. It's what we call post-ejection shortening. So things are very disorganized inside the heart because the timing is wrong. And you can bring it out more if you stress the patient with dobutamine. Okay? Now if you revascularize, and you can see that this isovolemic time is much shorter, and particularly on stress, now when the aortic valve closes, the ventricle stops contracting. So here is an example without putting wires into the heart, just by bypass grafting, how you can improve intraventricular conduction. And finally, just to remind you of, we've done a little bit of this work, but not very much. Spinali's group in the States have used microdialysis techniques. So this is very fine catheters about the size of a pacing wire that you can leave in the heart and take out about 20 hours afterwards. So the ability to study this over quite a long period. And you can see how during this period, here's a steady state period, the cross clamp goes on, there's a period of cardioplegic arrest, then there's myocardial reperfusion. And they were looking at MMP activity during this time. So just to indicate some of the things that can be done. So I think there are some unanswered questions still. We don't really know, even though some of us feel in our bones we do know, whether SVR works. So should we do a smaller Stitch 2 trial with surrogate endpoints, as I've suggested? I think that's a tough thing to do, but I'd like to hear what people think. And if we say, well, perhaps it does work, why does it work? So what is the effect of ventricular remodeling on intraventricular conduction, on myocardial energy and ECM metabolism, and what's its effect on work and power production. That would actually be a lot more interesting, I think. And thank you for your attention.
So in the meantime, John,